schizophrenia revision for your paper 3 exam. So what do you need to know? You need to know about the classification of schizophrenia, the reliability and validity in diagnosis of schizophrenia, biological explanation, psychological explanation, and biological and psychological treatments, as well as the interactionist approach to both explaining and treating schizophrenia. So classification of schizophrenia. We have our positive symptoms, which are an excess or distortion of normal functioning. So they're things that are present that wouldn't normally be found in a person with ideal mental health. So for example, hallucinations, they are the bizarre, unreal perceptions of the environment. Generally they are auditory, so hearing voices, but they can be visual, so they might see objects, lights or faces. They can be olfactory, so they smell things, or they could be tactile, so they might feel bugs are crawling underneath their skin or on their skin. Delusions are the bizarre beliefs that seem real to a person with schizophrenia, but they aren't. They can be paranoid. They can involve inflated beliefs about their own power and importance. Negative symptoms are a diminution or a loss of normal functioning, so they're things that should be present but aren't. So poverty of speech is characterised by the lessening of speech fluency and productivity, and it's thought to be a result of the slowing or blocked thoughts. Avolition is a reduction or inability to start or continue in goal-directed behaviour. So for example, they might sit in the house for hours doing nothing. So how do we diagnose it? You have the DSM-5, and it requires the person to show 2 or more criteria A symptoms. So they're your hallucinations, delusions, disorganised speech, grossly disorganised or catatonic behaviour, and the negative symptoms. They also require the person to display social and occupational dysfunction in 1 or more major areas in criteria B, and they need to have continuous signs of disturbance for at least 6 months and 1 month or more at the criteria A symptoms. The ICD-10, used in the UK and everywhere else, only 1 criteria A symptom is required if the delusions are bizarre or hallucinations involve hearing voices, particularly if they offer a running commentary about the person's life or 2 or more voices in conversation. So, is our diagnosis reliable and valid? So reliability, remember, refers to the consistency of diagnosis. So test-retest is when a clinician makes the same diagnosis on separate occasions from the same information. Research suggests that it isn't reliable, so reported the test-retest reliability of schizophrenic diagnosis to only have about 37% concordance rate, suggesting that it isn't fully reliable. Inter-rater reliability is where different clinicians make identical independent diagnoses of the same patient. So again, this was tested using the reliability of the ICD-10 in diagnosing schizophrenic. 100 Danish patients with a history of psychosis were assessed, and the findings of concordance rates was 98%. So it does show that we do have high inter-rater reliability. Validity is the accuracy of diagnosis. So are we accurately diagnosing someone with schizophrenia? So predictive validity is if we have been successful in diagnosing them, we should lead to successful treatment. So Mason et al. Found that it does have predictive validity. So they tested the ability of 4 different classification systems to diagnose and predict the outcomes of the disorder over a 13-year period in 99 schizophrenic patients. And they found modern classification systems had a high predictive validity, especially if the symptoms had lasted at least 6 months. Descriptive validity then is to be valid. Patients with schizophrenia should differ in their symptoms with other patients with other disorders. Now, Allardyce found there is a lot of differences between patients in what groupings of the symptoms they can experience. So it's not possible to diagnose schizophrenia as a separate disorder, so therefore the diagnoses are not valid. Comorbidity then refers to the presence of 1 or more additional disorder or disease occurring alongside schizophrenia. So Sims et al. Found that 32% of 142 hospitalised schizophrenics had an additional mental disorder. This illustrates the problem that comorbidity can create in achieving a reliable and valid diagnosis. Culture bias, then, is the tendency to overdiagnose members of other cultures as suffering from schizophrenia. So people of Afro-Caribbean descent are more likely to be diagnosed than white people. Whaley stated the main reason for this incidence of schizophrenia among Black Americans being greater than white Americans is culture bias. The ethnic differences in symptoms are overlooked or misinterpreted by the practitioners, so therefore it lacks validity in diagnosing schizophrenia cross-culturally. Another issue is gender bias, the tendency for diagnostic criteria to be applied differently to males and females, and for the differences in classification of the disorder. Lewin et al. Found that if clearer diagnostic criteria were applied, the number of female sufferers becomes lower, suggesting there is gender bias in the original diagnosis. Also, symptom overlap. The perception that symptoms of schizophrenic are also symptoms of other mental disorders. So another weakness is research compared 14 autistic patients with 14 sufferers of schizophrenia to find that none of the schizophrenics had symptoms of autism, but 7 of the autistics had symptoms of schizophrenia, showing some support for symptom overlap. So are we accurately diagnosing people with schizophrenic, or should they be diagnosed with another issue? So biological explanation, genetic explanations then, we can look at family studies, twin studies and adoption studies. Family studies have shown that the risk of developing schizophrenia is higher if the family history for it. So children with 2 schizophrenic parents had a higher concordance rate of 46%, compared to children with 1 schizophrenic parent with a concordance rate of 13%, and having a sibling with schizophrenia, a concordance rate of 9%. Joseph's twin study demonstrated that MZ twins have a higher concordance rate of 40.4% compared to DZ twins having a concordance rate of 7.4%, suggesting that schizophrenia could be genetic due to identical twins having a higher concordance rate. Adoption studies have also suggested that there is an inherited element. So adopted children with a schizophrenic mother, biological mother, are more likely than adopted children whose non-biological mother was non-schizophrenic to develop the disorder. So 6.7 of the adopted children whose biological mother had schizophrenia also received the diagnosis, compared to 2% of the non-schizophrenic biological mother adopted children. So evaluation, it could be down to other factors rather than genetics. So for example, many researchers now accept the fact that schizophrenia runs in families due to common rearing patterns. Research has shown that negative emotional climate in some families may lead to stress beyond the individual's coping mechanisms, which triggers the schizophrenic episode. The differences in concordance rates could be down to environmental differences, not genetics. So, for example, Joseph stated that MZ twins tend to be treated more similarly and have similar environments. And also there's a problem with selective placements in adoptions. So, for example, adoptive parents are likely to know the genetic background of the adoptees before adopting them. Therefore, children with schizophrenic mothers might be raised in different environments compared to those without schizophrenic mother. The dopamine hypothesis then. The original hypothesis claimed that the positive symptoms are caused by an excess level of dopamine. So schizophrenics have an excess of the D2 receptors on the receiving neuron, and this results in more dopamine binding and more neurons being fired. The revised hypothesis states that positive symptoms are caused by excess dopamine in the mesolimbic pathway, and the negative symptoms are believed to be due to a deficit, so a shortage of dopamine, in the mesocortical pathway. Abnormal levels of dopamine in both these areas cause symptoms of schizophrenia. So, strength is that antipsychotic drugs that reduce the activity of dopamine have shown to be effective in treating schizophrenia. Also, Mandrup and Montcalf induce schizophrenic-like behaviour in rats by giving them amphetamines, so it increases the dopamine production, and then reverse the effects by giving them neuroplagic drugs, which inhibit the release of dopamine. However, we can include our counter-argument about the use of non-human animals. PET scans have failed to find convincing evidence of altered levels of dopamine in the brains of individuals with schizophrenia, so it's inconclusive. Neural correlate then, so the prefrontal cortex. Cognitive symptoms of schizophrenia result in deficits from within the prefrontal cortex and connections with the other brain areas. So it's found that the hippocampal dysfunction was linked to cognitive impairment in schizophrenics. Also, there is reduced white matter pathways and grey matter. So individuals with schizophrenia have reduced volumes of grey matter and reduced white matter pathways. Individuals with schizophrenia show steeper rates of grey matter loss and reduced white matter in the prefrontal cortex connection with the hippocampus. So it just suggests there are brain structural abnormalities within individuals with schizophrenia. So, supporting evidence, schizophrenic patients show significant grey matter loss over time. Grey matter reduction was mostly in the frontal and temporal and parietal lobes. Also, there are practical applications. Early detection and intervention may prevent the development of the disorder. And much of the research is correlational, so it's problematic. We cannot say that lower grey matter causes schizophrenia, and it could be that the symptoms of schizophrenia. Psychological explanation, so we need to be aware of family dysfunction, and we're going to look at expressed emotion and double-bind theory. So this is the idea that the presence of problems within a family that contributes to the relapse rates in a recovering schizophrenic. So it includes a lack of warmth between parents and the child, dysfunctional communication patterns, and parental overprotection. So the double-bind theory states that children who frequently receive contradictory verbal and non-verbal messages from the parents develop incoherent representations of reality, which could lead them to develop schizophrenia. So a mother that tells her son that she loves him but turns away when he approaches her for affection. These contradictions cancel each other, stopping an internally coherent creation of reality from developing. So it was found that schizophrenic parents record more double-bind statements by their mothers than non-schizophrenics. However, patients' recall may be unreliable, and other studies have found no difference in the communication patterns in families of schizophrenic and non-schizophrenics. Expressed emotion is the communication style whereby family members talk about schizophrenic critically, so high EE, or non-critically, low EE. So in high EE family, the family members may be emotionally overly involved or concerned with the person and their behaviour. And patients returning to a high EE family are 4 times more likely to relapse than those with a low EE family. Schizophrenics may be less able to cope with the negative emotional environment, leading to stress beyond a manageable level. So a weakness is that schizophrenics differ in their vulnerability to the influence of high EE. So it was found that 25% of schizophrenics showed no physiological response to stressful comments, and suggested that whether EE produces a stressful response or not is dependent on how the schizophrenic themselves perceive it. So it shows that not all schizophrenics are equally vulnerable to high EE levels in their family. So continuing with psychological explanation, now looking at the cognitive explanation. So cognitive explanations state that abnormalities in cognitive function are a key component in the development of schizophrenia. So people with schizophrenia have dysfunctional thought processing. So hallucinations happen because a person attributes a self-generated sound to an external source. So even though they've made the sound themselves, they've misattributed it to an external source. And the voice is experienced as coming from an external source because the person doesn't check its actual source of information. Delusions happen when a person relates irrelevant information to themselves and therefore make false conclusions. They interpret irrelevant events as relating to themselves and criticisms, and they are unwilling to consider that they may be wrong or consider more realistic explanation, so they have impaired insight. So the supporting evidence, so schizophrenics with positive symptoms shows biases in informational processing, and schizophrenics with negative symptoms display dysfunctional thought processes such as low expectations of pleasure. Also, there are effective treatments. So CBT for psychosis was found to be more effective than antipsychotic drugs in reducing symptoms. Also, it focuses on changing cognitions about delusions and hallucinations rather than altering the brain chemistry, so it supports the idea that faulty thought processes are the cause of schizophrenia. Biological treatments then. Antipsychotics, these are drugs that are used to reduce the intensity of schizophrenic symptoms, in particular the positive symptoms such as hallucinations and delusions. They're usually taken in tablet form or in the form of a syrup, but in some cases the patients can be injected if they fail to take the antipsychotics themselves. They are divided into two types, typical, which are traditional, and atypical, which are the newer antipsychotics. Typical antipsychotics are dopamine antagonists. They work by blocking dopamine receptors at the synapse of the brain, reducing the action of dopamine. They affect the D2 receptors in the mesolimbic pathway. However, they also affect the D2 receptors in other areas, which can lead to extrapyramidal side effects. So, chlordiazepam significantly reduces hallucinations and delusions within a few days, and other positive symptoms such as thought disturbances will take slightly longer to reduce. So the effectiveness of conventional typical antipsychotics. So research has shown that they are effective in reducing the symptoms of schizophrenia, particularly the positive symptoms. So Davis et al. Reviewed 29 studies and found that relapse rate occurred in 55% of those who were on the placebo drug, compared to 19 who remained on the drug, so suggesting that they are an effective form of treatment. However, there are long-term side effects. So more than 20 patients who take these drugs for over a year develop tardive dyskinesia. Symptoms include involuntary sucking and chewing and jerky movement of the limbs and writhing movements of the face or the mouth. It is also found that after 25 years on constant treatment, this tardive dyskinesia was found in 68% of users, so therefore they might not be an appropriate form of treatment. Atypical antipsychotics block the D2 receptors, but they also act on serotonin and glutamate receptors. They believe that these help to improve mood and reduce depression and anxiety in patients, as well as improving their cognitive functioning. It's also believed they also work by treating the negative symptoms as well as the positive symptoms. They have a lower risk of extrapyramidal side effects because they have little effect on the dopamine systems controlling the movement. So an advantage of them is they have fewer side effects than typical antipsychotics, and therefore patients are more likely to continue their medication, so therefore they are appropriate. However, the appropriateness is also questioned by the fact that these drugs do not work for all patients. Approximately 15% do not respond to atypical antipsychotics, so are they appropriate for all patients? CBT is a form of psychological treatment, and it attempts to modify the thought patterns to alter the behavioural and emotional states. One of the major symptoms of schizophrenia is cognitive distortion, and CBT aims to deal with this disorganisation. CBT makes connections between a patient's feelings and thought patterns that reinforce their illness and makes the patient aware of these. They challenge the patient's interpretation of events and help them to change their habit of thinking about things in a pathological way. So if a patient has a delusion that the MI5 are following them, a CBT therapist would ask them to discuss the evidence they have for this. It not only helps with the symptoms of hallucinations and delusion, but it also allows the patient to become better at problem solving and coping with their illness, because the therapy lets the patient do the hard work of challenging their own perceptions. The sessions can take between 5 and 20 sessions, delivered in groups or one-to-one. It allows the patient to make adjustments to their thinking and help them to cope, so it just does not get rid of the symptoms. Schizophrenic people are often unaware they are subject to cognitive errors or that they are problems in their thinking. The therapist will make these maladaptive thoughts conscious and then challenge them, and then the patient will see there is no basis for these thoughts. For delusional thoughts, the patient is made to consider the evidence. As we've already talked about, the therapist will also set behavioural assignments for a patient to challenge these dysfunctional thoughts and encourage levels of functioning. So, for example, a patient believes they can predict the future, may be asked to predict what is happening next during a poor TV show. By testing their beliefs, the patients can acknowledge their faulty thinking and then change it. CBT offers psychological explanations for the symptoms that the patient is experiencing. In understanding why they are happening, the patient will hopefully see that they are not part of reality. So we've got some supporting evidence. So the findings from a number of studies, so 32 studies, and it was found that CBT had a small but significant effect on both positive and negative symptoms. The effects of CBT with a specific focus of benefiting the reduction in suicidal thoughts. And given that 30 to 50% of patients attempt it at some point, it is important. 99 patients were split into two groups, CBT and no CBT. All had been resistant to antipsychotics. CBT was found to reduce suicidal ideation both immediately after the therapy and the follow-up 9 months later. There are methodological problems with the research conducted in CBT. Most of the research that reports a positive effect of CBT on schizophrenia include patients who also receive antipsychotics at the same time, so it makes it difficult to distinguish between the effects of the drug and CBD treatment. While CBT improves the quality of life, allowing the schizophrenic patient to acknowledge their irrational thoughts and change their behaviour doesn't actually get rid of the symptoms. Family therapies. Family therapy is also referred to as psychoeducation, and it was developed in the 1980s to counter the problems experienced in high expressed emotions. The aims of the therapy is to educate relatives about schizophrenia, to stabilise the social authority of the doctor and the family, to improve how family communicate and handle a situation, to teach patients and carers more effective stress management techniques, and to reduce the level of expressed emotion within the family. So there is less stress with regards to caring of the schizophrenic. It reduces the anger and the guilt of family members. Family members still have time for themselves, and it challenges and changes the negative beliefs of schizophrenia. So there is supporting evidence in regards to the effectiveness. So several studies were reviewed, and it was concluded there were lower relapse rates within a year amongst those who had received family therapy. There are also long-term benefits. The patient is supported whilst outside of the institution, and the skills gained should support the patient even after the therapy has completed. However, it requires the family members to be willing to engage with the therapist. Therefore, it may not be available to all if their family members are not around or simply not willing to get involved. Token economy is based on operant conditioning. It's called behaviour modification technique, and it's a management for schizophrenia. 3 main steps: identify the undesirable or maladaptive behaviour, identify the reinforcers for that behaviour, and restructure the environment so the undesirable behaviour is no longer reinforced. So when patients with schizophrenia spend a long time in hospital, they can become institutionalised. They develop patterns of behaviour which would not be helpful in the real world. So for example, due to a lack of motivation, they may spend all day in their pyjamas and not wash themselves. Token economies aim to modify this behaviour so that the patient can work their way up to being able to live outside of the hospital setting. A list of desired behaviours are first drawn up. What do the psychiatrists want the patients to be doing, what they're not? The desired behaviour is allocated a number of tokens. These tokens are secondary reinforcers, something that could be used to gain a primary reinforcer, so a reward. A list of rewards will be drawn up, things that the patients can buy with their tokens. So for example, they may get exchanged for their tokens for time outside, watching TV, other privileges. So they are effective in producing better relationships between patients and psychiatrists. They can help with the smooth daily functioning of a psychiatric hospital. They build up a trusting relationship. However, it's just a modifying behaviour. If the patient did eventually re-enter society, they would no longer be rewarded for such behaviour, such as making a bed or getting dressed, and it's therefore possible that they'd stop with the desired behaviour and will not be able to function properly and outside of the institution, and therefore relapse into schizophrenia. Another issue is the use of token economies is that unlike drug treatments, they do not actually get rid of the symptoms such as hallucinations or delusions, so they're not actually targeting the cause of schizophrenia in any way. The interactionist approach for schizophrenia is holistic. It acknowledges that a variety of things can lead in the development of schizophrenia. They recognise the role of biological, societal and psychological factors. Whilst biological factors could include genetics and psychological factors could include dysfunctional thoughts. The diathesis stress model points to the idea that someone may be vulnerable to schizophrenia, so the diathesis part, but will only develop the disorder if something triggers it, the stressor. So it states that there is a schizogene, and this is a single gene that leads to someone being vulnerable to schizophrenia. Without the gene, it is not possible to develop schizophrenia, but having the gene doesn't mean that you will always get the disorder. The gene may leave someone with a personality that is particularly sensitive to criticism. So if they don't have an overly critical parent, they will not develop schizophrenia, but if they do, that will trigger the disorder. The diathesis part is the schizogene, while the stressor is said to be the schizophrenic mother. Also, there is pointed to be a different vulnerability, so childhood trauma. They argue that childhood trauma alters the developing brain, leaving a person more vulnerable to schizophrenia, and it can be triggered by an environmental factor. The stress element of schizophrenia may not be always a psychological factor. Others have pointed out that cannabis use can lead to schizophrenia and therefore acts as the trigger for those who have a vulnerability to develop schizophrenia. How does this affect the treatment then? Treatment according to the diathesis model is mainly used in the UK, where an interactionist approach is common. It is common practice for psychiatrists to offer antipsychotic medication along with psychological treatments such as CBT. In the UK, it's becoming more common to treat patients with a combination of drugs and CBT. In the US, there is more conflict between psychological and biological models, which could have led to the slower adoption of the interactionist approach. There are practical implications. So women infected with cryptomegalovirus during pregnancy are more likely to have a child who later develops schizophrenia, but only if the mother and the child carried the particular gene defect. An antivirus medication during pregnancy could protect children from this gene or developing the disorder. Treating the patient using more than one type of treatment means that every aspect of schizophrenia is targeted. Also, patients in the two combination groups showed lower symptom levels than those in the control groups in medication. And the fact that combined biological and psychological treatments are more effective than either on their own does not necessarily mean that the interactionist approach of schizophrenia is correct.